Hello, we are Group 3 and we are going to be evaluating the health program LEED, Live Every Day Educated with Diabetes. LEED's mission is to educate adults with diabetes and their families on diabetes management. This will promote ownership of the disease and result in better hemoglobin A1C levels. These outcomes will be achieved by continued education on proper diabetes management, nutrition, and physical activity, as well as motivational phone calls and visits with their doctors. The primary objective is that upon completion of the program, 90% of participants will have hemoglobin A1C levels below 6.5%. The secondary objective is, after 6 months of participating in the program, 90% of participants will be able to explain the effects of weight, blood pressure, cholesterol, smoking, and the importance of physical activity and diet on diabetes management and the complications associated with diabetes. The tertiary objective is, upon completion of the program, 85% of participants will report receiving increased support from family members. The final objective is, participants will attend 95% of the meetings throughout the program. LEED utilized the social cognitive theory to construct the program. According to the social cognitive theory, all three components of the model have a heavy influence on each other. The behavioral factors addressed are diet, exercise, completion of glucose monitoring worksheets, and properly adhering to medications. Personal factors influenced by these behavioral factors include self-efficacy and the current physical health of the participant. In turn, self-efficacy will also influence the behavioral factors. The environmental factor, which is a supportive home life, will also positively influence the other two components. Through recognizing what behaviors to change, participants will be able to lower their hemoglobin A1C levels to a normal level. To measure the attendance objective of the participants, we will subjectively measure attendance sheets and tracking. This is considered nominal data because the participants were either present or absent. To evaluate the secondary objective, we will subjectively measure the participants' knowledge on diabetes by collecting questionnaires. Pre-test questionnaires will evaluate prior knowledge, while post-test questionnaires will test the level of knowledge and comprehension after the intervention. This will also be nominal data because it is asking the participants questions that have mutually exclusive answers, such as multiple choice questions. The LEED program will be conducted using a quasi-experimental pre-test post-test design with 1 pre-test and 3 post-tests following the intervention. The unit of randomization will be community clinics in the San Diego Bay Area, with 3 community clinics receiving intervention and 3 not receiving intervention. The intervention group will receive education on diabetes, while the comparison group will receive skin cancer screening as attention control. We will recruit 300 participants for the experimental group and 300 participants for the comparison group, for a total of 600 participants. This timeline shows that all potential participants will undergo an initial physical exam and complete an initial pre-test questionnaire. During the 12 months of the program, each participant will attend 18 educational sessions, have 4 physical exams, complete 4 questionnaires, and receive 156 scheduled phone calls from LEED volunteers. 2 major evaluating components of the program are physical exams and assessment questionnaires. Each participant will have 4 physical exams and will fill out questionnaires at enrollment, 6 months, 9 months, and at the end of the program at 12 months. The advantages of the evaluation plan include: by doing both pre-test and post-test, we will be able to gather baseline data from both the intervention group and the comparison group and see the effectiveness of the program after intervention implementation. By having a comparison group, the program can provide interpretable and supportive data that will show that having an education on diabetes, related complications, and nutrition can benefit adults with diabetes and help improve their hemoglobin A1C levels to below 6.5% as compared to adults with diabetes who receive standard care. The disadvantages of the plan include: firstly, quasi-experimental designs usually cannot control for all factors that affect the validity of the results. For example, the lack of randomization poses as a threat to the internal validity of the intervention. Without randomization, other conclusions, such as the health status of South Bay San Diego, cannot be made with complete validity. Another disadvantage includes the circumstances in which LEED was implemented. This circumstance requires that a comparison group must be applied to the intervention rather than the idea of a control group. This comparison group will be receiving skin cancer screening as attention control to reduce the possibility of contamination. However, with pre-testing and involvement in health education, behaviors may change and result in the comparison groups can be skewed. Another issue would be the Hawthorne effect. The Hawthorne effect could modify or improve an aspect of the participant's behavior in response to their awareness of being observed. This can lead to more desirable results in both populations in the intervention. This concludes our presentation. Thank you.